So my name is Nang-Tege. My name is Nang-Tege. A lot of you that have known me um over the years may probably know me by Daniel. It's still the same person, Nang-Tege or Daniel. I just more ascribe to my Africanism now than before, and so you might hear me most of the time use that. Um, can you see my screen, please? If that is fine with everyone, just give me a shout, and then I will proceed with the presentation. And a verbal confirmation that the presentation can be seen, please. Oh,
Yes, Daniel, we can see your screen.
okay. So today we're going to be discussing unconscious or implicit bias, and your aim for this session is primarily going to explore the topic, um, and then to see how the language that we use in our daily encounter with our patients, in our daily interactions with our colleagues, tend to affect the quality of care or the level of care that we provide to these patients. Also, to look at how this can impact team dynamics um, within healthcare delivery teams, whereas uh, sometimes we tend to have a lot of frictions, not because of work, but just because of some of these implicit or unconscious biases that we hold against each other as colleagues, and even that we hold against the patients that or the clients that come to us for services. The focus particularly is going to look at what unconscious bias or implicit bias is, who is affected the most, and then how to mitigate unconscious and implicit bias. Now, I've always wanted presentations to be a bit interactive. So if you could just do me a favor and scan that QR code that you can see on your screen and just tell me in one word or in a phrase what comes to mind when you hear the word unconscious bias. And I'll just read out to you guys some of the responses that are coming through. So if you are very happy to share with us your opinion on what unconscious bias is to you, I'll just give it a minute or two just to get the results showing on my screen. Is the QR code working for everyone, please? It did work for me just a minute ago, and I think it's still. Okay, so whilst we're waiting for that to the results to get in, I'm just going to go forward with the presentation. Okay. So we just want to look at unconscious bias in the words of other people. And then it is stated that implicit or unconscious bias is unintentional. That is, and these are the catchwords that I want you to probably get your mind around. One is unintentional. Um, Two is preconceived notions. Three is a perception that you hold against someone or about a group of people. And this can lead to reflexivity that influences either your behavior, your interaction. But most importantly, in healthcare, we are looking at how this affects our decision making process in our interactions with our patients on a day to day basis. Now, if you look at how this can impact the care that we deliver, it boils down to an error in systemic decision making. So our biases, whether we are referring to it as innate bias, as inherent bias, as covert discrimination, as casual prejudice, many synonyms that we can find here and there, what usually happens is that this affects our clinical decision making on a day-to-day basis when we are interacting with our patients. That is one aspect. This also impacts our relations with our colleagues when we are working together. And this in the long run, again, goes back to affecting these patients that we are interacting with on a very day-to-day basis. Now, to understand, to accept the fact that unconscious bias is part of the healthcare profession, it is a part of the human society. So denying it is not going to help. It is more that if we are able to accept that this is a fact, we have unconscious biases. It is a part of us. These unconscious biases are automatic and we do associate them in our interactions every day, whether at the workplace or out of the workplace. This will then lead us to addressing or desiring or wanting to address how crucial this impact healthcare. And I'm just going to share a video with you guys that talks about how ingrained unconscious bias is in our daily interactions and then in most of our clinical decision making processes. Just give me a minute to share you this video, which will intrigue you. I think I want to. Oh yeah. And please hear the voice. Okay, so that was just a quick video on implicit bias, and I hope that you guys managed to hear it clear. I'm going to go back to the slides, and then we'll continue with the presentation. And there are one or two other videos that I will be sharing with you just to help draw home the message of implicit or unconscious bias in our day-to-day encounter. Let's get back to the presentation. Okay. So we are back. So basically, that is what, if you had that video play, these are the things that you get with relation to unconscious or implicit bias. These are things that we have grown up having them being part of our life. These are perceptions that we hold um, around people that we think that are right, and it's affecting our day-to-day interactions with our patients. Now, to understand where implicit bias is all coming from, we need to go back to Sigmund Freud's view of the human mind and appreciating the fact that about 90% of our daily interactions or the processes that go on in our heads are usually from the unconscious and subconscious mind. It goes to tell you how we might not be aware of the implicit or unconscious biases that we hold in our day-to-day interactions with people. And so this is something that we need to consciously prompt ourselves about, the fact that if 90% of the decision-making process or the influences of the decision-making process that I am having is subconsciously or unconsciously influenced, it goes to tell you how we need to double check every time these decision making processes, every time these interactions that we are having with people, just to make sure that we are not unconsciously being biased or implicitly being biased against the patients that we are taking care of or against our colleagues that we are working with. Now, there are so many types of implicit or unconscious bias that you would find out there in literature, including affinity bias, attribution bias, beauty bias, conformity bias, confirmation, gender, the halo effect, the contrast effect, ageism, and name bias. And some of these are straightforward, but I will tend to speak about some that are a bit more common with the healthcare delivery sector or with us as healthcare professionals in our day-to-day interactions with our patients. And you will come to understand how even the best of decisions that sometimes we think we are making for the patient is influenced by some form of implicit or unconscious bias. Most of the time, we get to know, or we can double check that we are having an implicit or unconscious bias towards a patient or a colleague when we listen to ourselves speak, which I know is a very difficult practice to have. But if you will consciously look at, okay, what did I say, or what is the meaning of what I said, or what could have informed what I said, we will begin to realize that most of our statements, most of our interactions have an undertone of an implicit or an unconscious bias. Let's look at a few examples of statements that might have implicit or unconscious bias connotation. For example, if you tell a colleague at the workplace, you are well spoken, that is really impressive. Generally, this is a very positive one, a comment that you are making. But if you want to take a step back and reflect on this statement and look at it As in, if you are speaking to someone probably from a racial minority group or from a cultural minority group, or maybe even educational wise, if you are speaking to a colleague that you are maybe academically advanced, as in maybe you have a degree, they don't have a degree, you have a master's, they don't have a master's, and you make a statement like, oh, you are well spoken, that is really impressive. You might think this is a compliment, but looking at it in another lens or coming from the perspective of implicit and unconscious bias, there is an element of bias here. The fact that could they not be well spoken if they were not that race, particularly speaking? Or, for example, if you are speaking to a patient from an ethnic minority or a racial minority group, and then a statement like, I did not expect you to have such sophisticated understanding of medical technologies. And this is more of just an example, but in our day-to-day presentations or in our day-to-day interactions with our patients, sometimes we get taken aback when our patients tell us certain things they know either about their condition or either about the treatment plan that we are giving to them or even the care that we are providing for them. And we tend to be so surprised that we make such comments. Oh, I didn't expect you to understand the effects of, for example, paracetamol, or I didn't expect you to understand how we tried here. This is to say, there are so many comments, there are so many languages, there are so many statements that we make in our day-to-day interactions with these clients, with these patients, that clearly shows that we have some level of implicit bias against them, either it is race, gender, age, or even weight. Another one that I want to probably use, and I use very common as an example, is my name, Nang-Tege, is not a traditional British name. Now, there have been times that I say, oh, my name is Nang-Tege, and somebody is impressed with the little work I've done and say that, oh, Nang-Tege is an exceptional international nurse. Okay, that is a compliment on the face value. But I don't know if you see a bit of an implicit or unconscious bias as to the fact that the word international is inserted there. So if I am an exceptional nurse, or you are an exceptional nurse, or you are an exceptional colleague, the fact that we have just qualified it as international makes this whole thing draw an element of explicit or unconscious bias. And we do this in various forms. Like we just hear a name of another person and we conclude, or we make assumptions, or we prejudice. And let me make this a bit clear. It is not about just the conclusion or the prejudice, it's the way this goes on to affect our decision-making process, particularly when we are caring for these patients, because it will just probably prejudice us to think the person doesn't know much about their condition. The person shouldn't know much about the side effect. And so our judgments, the choices that we make for these people are sometimes affected by some of these implicit or unconscious biases that we have. Gender wise, for example, maybe there is a lot of research out there that talks about heart conditions more common in males. It doesn't mean that females might not have a heart condition. And so there is a female client or patient in front of you displaying signs and symptoms or showing you pathognomonics of heart conditions. But just because there is a bit of literature out there that supports the prevalence in male, we tend to say, oh, it is very unusual for female patients to have heart conditions. What can this do? It limits the opportunity for you to probably question the possibility of this female patient having a heart condition. It's going to affect your decision-making process, the type of test that you order for them, even the treatments that you order for them. And sometimes we arrive at a final diagnosis and best treatment when it is late. When dealing with our colleagues, looking at it from a gender perspective and being a male, if I tend to tell another colleague or describe another female colleague to say that, oh, Dr. Rita, for example, is an exceptional female lecturer or is an exceptional female clinician, Yes, it might be a comment on the face, it might be a compliment on the face value, but I can tell you that such comments have implicit and unconscious bias for the fact that could they not have just been an exceptional lecturer? Could they not have just been an exceptional clinician? Did I have to be very specific or explicit about the fact that they are a female lecturer or clinician? We make statements like people being too learned for their age or being too knowledgeable for their age. We make statements and we make assumptions from the fact that, oh, overweight people struggle with being disciplined when we talk about diet. And so sometimes we might feel to even prescribe diet interventions for patients that are probably struggling with overweight. And research has proven that sometimes it's not just the issue about discipline, but we, because of our implicit and unconscious biases, tend to forget that there are other factors, like there are mental health related factors that limit the ability of such people to be able to stay disciplined to treatment regimens that have given them. There is that that biopsychosocial factors that we fail to examine or to look at just because we've got this implicit bias is that once somebody is overweight, they are not disciplined with diet. Now, I had wanted us to make a discussion about this, but I think we started a bit late, so I just went on talking about this. But do you agree with me that the above statements demonstrates elements of implicit or unconscious biases? And if yes, what are some of the reasons personally to you? And you can reflect on this later on, putting into context some of the very comments that we make ourselves on a daily basis regarding our colleagues, regarding the patients that we are taking care of, regarding the clients that are in front of us, seeking for the best possible care that we can give to them. Now, we want to talk specifically about how unconscious bias or implicit bias is displayed, particularly within the clinical settings. And I've just picked about three types that I want to highlight a little bit on, and then we can see other examples, or we can take this into practice and look at, okay, how am I, or how is implicit or unconscious bias affecting my interactions with my patients? How is it impacting the quality of care for my patient? How is it even impacting the team dynamics and the interactions that I have with my colleague? Now, one of the types that I have chosen to speak about today is anchoring bias. And by the sorry, by the text and by the little reading that I have done, you would understand that anchoring occurs when the health professional relies too much on their initial diagnosis or prognosis, even when there is information to suggest a change. And I've given an example of in a difficult airway management, the bias can delay recognition of patients, changing clinical status. So, because probably we didn't foresee, probably because mostly in anesthesia or in emergency medicine, we've got things like the if I can remember practically, the Malampati score for difficult airway. I hope I'm not mixing my clinical ideas at this point in time. But because we think that a patient might not have a difficult airway, does not mean that they will not have a difficult airway, and vice versa. Availability bias involves basing diagnosis and treatment on recent or easily accessible information. A typical example that I will probably put in this clinical context will be that how many times have we not quickly diagnosed people as having COVID when they are not having COVID, just because we have so much resources around now and so many things out there that just talk about if a patient presents with ABC is COVID. Vice versa, we find ourselves in influenza season and we tend to diagnose everyone with influenza because that is what is running around. So because there is that availability of information, there is that availability of treatment, we tend to put patients or push patients towards those diagnoses, towards the use of those resources, regardless of whether they fit into that criteria or not. Typical practical example that probably I have seen both in the global south and in the global north. For example, when it talks about resources and you are looking at things like uh, 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 managing patients with flus. Now, you would realize that probably in practice, you tend to use a lot of normal saline just because normal saline is always available when you are doing fluid resuscitation. So everybody that is struggling with some form of fluid deficit, we are running first to normal saline. We're running first to normal saline. We're not evaluating the other options that are there. We are not even looking at the fact that, okay, yes, there is fluid deficit, but there could also be alongside electrolyte deficit. And so it's not just about replacing the fluid, but it is also about replacing that electrolyte deficit. And so instead of going for normal saline, could we probably do a Hartmann solution? If this patient probably has issues with their potassium, are we looking at some form of fluid containing potassium that could both address the fluid challenge, but also address the electrolyte imbalance that is ongoing? And so sometimes because of the availability of resources of information, we tend to be biased in our clinical decision making and then in our treatments of this patient. Confirmation bias basically talks about when we try to use every information around to support a diagnosis that we have made, if even we are finding contradictory evidences against what we initially thought that was there. And you realize that anchoring bias, availability bias, and then confirmation bias kind of interrelate with each other when we talk about the clinical settings. Now, I will leave this video, looking at the time, I'll leave this video till the end to play one of them for us to look at because of the technological intricacies of switching screens and also getting these videos back on sharing. But the impact of implicit bias, unconscious prejudice is one of the contributing factors to health disparities, whether you find yourself in the global north, whether you find yourself in the global south. And in one of the videos which I'll play, it's not just about the diagnosis and treatments of patients. It is also about the costs, the health associated costs that is bringing, not just to these patients, but also to the institutions that we find ourselves in. And you will find out that from the disparity in pain medications. So, for example, there is this generalized, well ingrained implicit bias about the fact that people with color deal with pain better. And so there is a lot of publication out there that sees that we are less generous with analgesics when we are treating people of color. Again, there is growing evidence that people of color tend not to know much about their health conditions. And so we tend not to want to give them all the information that they want. Whereas, because there is this association that people of lighter color or people from the global north are more knowledgeable about their health conditions, we tend to be very careful when we are interacting with them, knowing that, okay, we would have to discuss the whole spectrum or scope of the disease, the possible treatment options that are available, and to allow them to make an informed choice. Whereas in other settings, we realize that there is nothing about informed choices when it even comes to treatment options. And these are all some of the impacts, short-term, long-term, medium-term impacts of implicit bias. Now, we can also go ahead to categorize the impacts of implicit or unconscious bias in the healthcare in so many different ways. And Vela et al. 2022 have done so fantastic in putting examples of these for us. As in health, this can affect the patient-provider communication, patient-provider relation, patient satisfaction, and so on. Resource allocation-wise, is bias affecting the way the healthcare system allocates the resources? We don't need to probably go way back. We probably just need to look at the just ended global pandemic, COVID, and it will fascinate you to know that implicit or unconscious bias influence the whole um, response to that particular pandemic, because we had so many comments about the fact that it is coming from somewhere, about the fact that, oh, some people should be allowed to face it as their fate, about the fact that some other people should be protected more than others. So just to let you know that even in our day-to-day distribution of resources within our healthcare delivery system, whether you are in primary care, you are in secondary care, or you are tertiary care, implicit and unconscious bias is affecting our decision making. And this have repercussions not just on the delivery of care, but also on the outcomes of these patients that entrust their lives into our hands. Within the profession, the workplace, how even trainings are done, how even people are selected to go on trainings, all these are affected by implicit and unconscious bias. And until we accept this fact as a part of us as human beings and put in the measures to mitigate this, we will continuously be shooting ourselves in the foot. We will continuously be fighting a lost battle when we talk about patient-centered care, when we talk about improving the outcome of the care that we provide for our patients. Now, some of the mitigative strategies or interventions that have come across within the time frame includes more of a personalized approach, but also an organizationalized approach. So there is a responsibility on us as professionals. Myself as a nurse, you as a nurse, you as a doctor, you as a paramedic, to look into ourselves and try to pick out those prejudice, those implicit, unconscious thought processes that affect our decision making, to take a break and look at every decision we are making, or to second double check every decision, every thought process. You say, has this been, am I arriving at that decision because of an implicit bias to this individual, to this patient, to this colleague of mine? And that is our personal responsibilities. But also, we are not going to succeed as individuals without the organizational support. And so the organizations that we find ourselves in have a role to play in setting up the environment, in providing the resources, in providing the right culture, organizational culture, to make sure that people, for example, are bold enough to question implicit or unconscious bias when they see it within organizations. When they see a colleague being implicit or unconsciously biased to another colleague, to be bold to call them. That environment should be created. That room for diverse experiences, diverse opinions should be. And there should be a clear organizational policy when it comes to implicit and unconscious bias. And I know most of our organizations don't have this. We are failing to even recognize this is a part of the challenge that we face as healthcare delivery system. How are we going to make the effort to start making policies to make sure that the environment enables people to see this, to work towards this, and to improve this on a very daily basis? Some practical strategies that, again, going back to Vela et al. 2022, have tried to suggest to us when we are dealing with implicit and unconscious bias within healthcare is allyship training, bias literacy, brave space, emotional regulations, intergroup contact, photo voice, service learning, theater reading. And you will get to understand when you look at this this particular piece of literature, that sometimes, depending on the organization, depending on the situation, all what you need, for example, is to make people aware, is to provide resources, is to like for example, AFEM is doing today with this presentation, is to provide that literacy, is to make sure that we are educating ourselves. And this should not only be from probably an expert to people that don't know. We can just have simple workshops, simple discussions to pick up examples within our organization of how implicit and unconscious bias is being exhibited within our organization. There are a range of practices that are tailored to individuals that are more privileged. So, for example, will we be able to develop certain practice that will make maybe doctors evaluate their implicit or unconscious bias against nurses, nurses against nurses, nurses against doctors, nurses against healthcare assistants, nurses against paramedics, paramedics against nurses and doctors, that affect team dynamic. And can we do similar to identify these things? Because when we talk about the healthcare provider and the patient, we find ourselves in a more privileged or in a more advantageous position. And so we are most likely going to have an implicit or unconscious bias towards these people when it comes to things like their level of knowledge about their condition or even options of treatment. Brave space. How many of our environments are able to encourage people to speak up when they see elements of explicit or unconscious bias? Emotional regulation is more of a personal thing. Regardless of whatever your socialization orientation over the years have been, are you able, through emotional intelligence, to take a 30 seconds break and think and ask yourself, is this the right response? Is my response showing elements of implicit or unconscious bias towards this patient or towards my colleague? Intergroup connect. Now, some of our biases are developed out of quote unquote ignorance. So we barely know anything about the other individual or the other group. And so all our interactions are based on assumptions and projections. Now, research has found that it's very important sometimes to introduce people into groups that they barely know. And we can do this in various forms. We can simulate this. We can tend to get healthcare professionals to play the role of patients and get their colleague healthcare professionals be implicitly or unconsciously biased towards them. And then we can have feedback from these colleagues to say, how did you feel when the healthcare professional that was taking care of you ignored all the suggestions that you were given because their implicit bias is that the patient never knows much about their condition? How did you feel when you didn't get much information because the healthcare professionals' implicit or unconscious bias is that you would not understand if even they explain to you what the condition is? Other interventions like photo voice, service learning, and theater reading can all be explored, and there is literature to support some of these interventions. Now, what are our steps going forward when we are talking about implicit and unconscious bias in healthcare? To increase awareness, we are doing it today, but it's not just today, to continuously increase the awareness that implicit bias and unconscious bias is a part and parcel of our makeup as human beings because of the way we have been socialized over the years, because of the fact that we don't have all the information about certain people or certain groups of people. And so we need to continuously remind ourselves of the existence of implicit and unconscious bias. There is this resource that can make you assess yourself, which is the implicit association test. And then if you just Google implicit association test or implicit Harvard test, you will find a link. It's a free test that you can run for yourself to find out whether you have implicit bias on certain topics like gender, race, ethnicity, uh, and other things that you are talking about. Now, there is this other YouTube video that I wish that with time we could probably look at it, and I will ask the host if there is time to look at some of these videos. It's being bold and naming it. It's this organization that created safe space and safe wording. So whenever there is an issue with implicit bias, whenever there is evidence of unconscious bias, they don't just call you out as, oh, you are being biased towards the patient or this. They've developed a safe word that reminds each professional there that, okay, do you want to double check this decision? Do you want to double check that statement? Do you want to reevaluate your thinking process? So, for example, it could just be a cup of coffee. So if we are in a meeting and I make a statement that connotates implicit or unconscious bias, somebody can just say, Nang-Tege, cup of coffee. So without me feeling I have been called out, my implicit bias tendencies have been what? Brought to my attention. And so I look at a cup of coffee and what goes back to my mind is that, why did I make this statement? Was it informed by an implicit bias? Was it informed by an unconscious bias? But to do this not just once, but to do these over and over and over again, because we cannot eliminate unconscious bias. We cannot eliminate implicit bias. We can mitigate, we can reduce it to the barest minimum. We can keep on reminding ourselves of its impact on the healthcare system, on the quality of care that we provide for our patients. And then we can continuously improve this every day. Now, before I conclude, just as I was saying, there is a challenge, and the challenge is that the human brain is a complex organ with the wonderful power of enabling men to find reasons for continuing to believe whatever it is that he wants to believe. So if we don't challenge that belief, that the patient doesn't know much about their condition, that the patient can never understand the treatment option, that the patient cannot make informed decisions for themselves. And we don't challenge the belief that, okay, although we might have a degree and a colleague might have a diploma, but maybe clinical skills wise, they can be better than us, or not just being better, but even they can contribute more to the team. If we don't challenge that belief that a nurse could be as important as a doctor or a paramedic could be as important as a nurse in the healthcare delivery team, then we are going to continuously believe what we have or what we think, which is going to continuously affect the way we relate to our colleagues and the kind of care that we provide for our patients. So implicit or unconscious biases happens equally across the board, regardless of whether you're a nurse, you're a doctor, you're a paramedic, you're a healthcare assistant, you're a cleaner on the ward, or whatever. There is always some form of implicit or unconscious bias in our daily interactions. However, the more aware we are about these tendencies, the more we will try to cultivate the habits through sustained practice, feedback, and reflection to make sure that we continuously improve our interactions with our patients. We continuously improve our interactions with our colleagues, which has a very significant bearing on the quality of care that we provide and on the patient outcomes that we are looking for our patients on a daily basis. A couple of references to support this presentation. Thank you so very much for listening. And we'll take some questions before probably we will just take a quick feedback as to a feedback survey as to how the information that has been presented to you has been taken on board. Thank you very much. I am open to questions now.
Thank you very much, Daniel, for such an insightful presentation. I believe we all find ourselves in this presentation, and that we may need to do a bit better than we have been doing. The floor is open for questions. Anybody wants to ask is welcome to ask questions, contributions at this point in time. All right. If there are no questions or concerns or any comments, once again, thank you very much, Daniel, for this insightful presentation. We will be announcing the next webinar on our various platforms. So please look out for the flyers and then a link to our next presentation. Thank you once again, and have a wonderful afternoon wherever you are. Yeah, hello.
Yeah, so I promised to play a short video of a minute. I don't know.
There appears to be a question, Daniel.
Yeah. I'll take the question, but if there's a little bit of a minute or two, I also want to share this very important video on the impact cost-wise to the healthcare system. I'll take the question. Yeah.
The one with the question, please go ahead. All right, I think you can go ahead and show your video.
Yeah, just for us to appreciate how this is affecting even the more
And we are unable to hear the sound.
Listen, you cannot hear the sound. Emmanuel?
That's right.
Oh, that's strange because I had enabled to share the sound. So I'm actually surprised this is not sharing. Just give me a minute, I'm sorry. Just technology, yeah, sometimes. Okay, I'm going to share it again, and hopefully this time around we should have. I'm sharing sound that I am sure I'm sharing sound. So, okay, let's see.
Is there a link you can share this with us?
Yes, It's on the
If you
presentation.
can put it in the
So
excellent. Once we get the presentation, I'm sure we can watch it. And then if we have questions, you may give us your email address so that we can reach out to you for further questions and explanation.
fine.
If that's okay
That is
with you,
fine.
sir.
That is very much okay with me. Once the participants are very happy with that. Emmanuel, that's very fine.
Right then. On this excellent. On this note, we would like to thank everyone for joining, and we hope to see you in our next presentation. Thank you so much once again. Until then, have a nice day. Bye-bye.